So the MAIA trial looked at, the combination of daratumumab, Lendex versus Lendex in transplant-ineligible patients. In fact, it's an older patient population with 74 years of age at a median across the two arms. It showed better, depth of response, MRD negativity, primary endpoint of PFS, as well as overall survival now after 5 years of follow-up in favor of DRD. One of the critiques of the study was the high-risk population was, small, around 14 or 15%, and the benefit in the high risk was not very clear because of the low number of patients. But it appears with subsequent analyses that even in that group, the median PFS appears to be about 40-odd months. It's still not as good as the standard risk patient population, but it does appear like those patients do have some benefit. In the grand scheme of things, every clinical trial that we've had looking at daratumumab, there have been, a question about the role of daratumumab for high-risk patients. And my key takeaway is that, daratumumab probably does improve the depth of response and survival outcomes, but it's not to the same degree as that for standard risk patients. Part of the challenge is, all these trials looked at all comers and did not stratify or power the study to look at high-risk patients. On the converse, we actually have some studies that have been presented, here at the IMS, looking at the transplant-eligible patients getting daratumumab with KRD as part of induction. And it looks like those patients, at least in single, arm studies, are showing very deep responses. So, overall, we still question the role of DARA in all myeloma patients, but it does appear that there is, benefit to that subset in the MAIA trial.